Hi, good afternoon or good morning, depending on where you are. This is Elizabeth Hardig with the American Planning Association. Welcome to our 30-minute action-packed Healthy Communities Collaborative webinar. We're excited to have you here today. This webinar is being recorded. A copy of the recording will be sent to you via email in the next couple of days. We'll also include a link to some of the resources that you'll hear about today. You are welcome to submit questions throughout the webinar using the question box or chat box on the right-hand side of your screen. And with that, I will go ahead and get things started. So before we dive into the Community Health Assessment Toolkit, we wanted to take a moment and introduce the Healthy Communities Collaborative. And here today we have our chair of the HCC, Kayleen Koch. So Kayleen resides in Newark, New Jersey, and wears many hats. She is currently a grant manager for a consulting firm that supports local governments with oversight of EPA grants. She's also a special projects coordinator for the New Jersey chapter of the American Planning Association, and of course, the chair of the HCC. We actually met Kayleen through Plan for Health, where she was a project manager for the Plan for Health work in Trenton. And with that, I will hand things over to you, Kayleen.
Great. Thank you so much for the introduction, Elizabeth. So the Healthy Communities Collaborative is an interest group of the American Planning Association. The mission statement of the Healthy Communities Collaborative is, the Healthy Communities Collaborative is an American Planning Association interest group of planners and allied professionals who are interested in fostering cross-sector collaboration and increasing capacity to support building healthy communities through the local, regional, state, or national level. And this is really important in APA's network because they've signed on to promote healthy communities in the joint call to action with 7 other associations across the country, and it's also a legislative priority for APA. So the collaborative is something that builds upon the Plan for Health work that came out of APA, and we really want it to leverage the work that's already been done. We want to keep the momentum going. We want to provide resources for people that are getting started on this work. We want to connect each other to each other so that we are able to keep the momentum going and access different resources and leverage what's already been done. The structure of the HCC is one where we have a chair and an advisor. Grace Kwong is our advisor, and she is based out of St. Louis, and she was a part of Plan for Health as well. We have quarterly calls where we report back on the progress we've made throughout the past quarter. And so the progress that we're really reporting back on has to do with the working groups. And so we have 3 working groups. There's an education working group, a working group focused on partnerships and outreach, and a working group focused on policy. And so they have bi-monthly calls, and they are very focused on being action-oriented, and the goal is to have a product or something that will be resourceful to APA's network and beyond by the next National Planning Conference in New Orleans. And we really benefit from the support staff of APA. This really wouldn't be possible without them, and they are a great resource to us. And I think they also, this relationship really works well because they benefit from being a part of this collaborative because they're able to see what the members need regarding to healthy communities. So this brings me to my next point. We really, on each quarterly call, we'd like to create a needs share platform where people can share what opportunities and what they're celebrating, but they also can express their needs, and hopefully it gives an opportunity that people, other members on the call can address their needs and point them in the right direction, or APA can see where there's more needs for them to focus on. Some opportunities to get involved are coming up real soon. The next opportunity is the Partnerships Subcommittee call, and that's on Tuesday, October 17th. And I believe if you download this presentation, you will have links to the registration. There's also the policy one. That's on October 31st. And before that, there's the education subcommittee call, and that's October 24th. So they are for 3 Tuesdays in a row, and you can join just one of them or all of them. If you want to get more involved, you can give me an email at kayleenkoch@gmail.com. If you just simply want to join the listserv, the Planning Community Health Center can facilitate that, and you can just email health@planning.org. Now I have the great pleasure to introduce you to Julia Resnick, who is a Senior Program Manager with the Association for Community Health Improvement and the Health Research and Educational Trust. Julia develops the educational curriculum, analyzes survey data, and planning for the national conference at the Association for Community Health Improvement. She works on a variety of population health-related projects through the American Hospital Association Health Research and Educational Trust, including leading the Population Health Task Force and writing guides for hospitals in pursuit of excellence. She is very passionate about fostering a healthcare system that aims to keep people healthy. Julia received her Master of Public Health at Hebrew University's Braun School of Public Health and Community Medicine and a Bachelor of Arts in Sociology from Bates College. So, Julia, take it from here.
Thank you so much, Kayleen, and it is such a pleasure to be here. I went to my first planning conference about a year and a half ago. It was just really exciting for me to be there and hear people talking about the same issues that I care about and that we focus on in healthcare, but from a slightly different angle. And there are just clearly so many synergies between the work of community health and what's going on in planning that it opened up a whole new world for me. So it's exciting for me to be here to be able to talk with you all about something that I think we're all passionate about. So thank you so much for inviting me. So a little background on where I come from, because I know we're organizationally confusing and have lots of acronyms and layers, which I'm sure none of you are familiar with at all. I work for the American Hospital Association, which is the major trade organization that leads, represents, and serves hospitals across and health systems across America. So I think somewhere over 90% of the hospitals in the country fall under our membership. And what the work we do is to support them in the field as they advance. Within that, I work for the Health Research and Educational Trust, which is the nonprofit arm of the American Hospital Association. As our name implies, we do a lot of health research and education, a lot of work in quality improvement, trying to help hospitals inside their walls treat their patients as well as possible. And then within that, as I was saying, complicated organization is our Association for Community Health Improvement, which is a personal membership group that is for people who work in community health. And much as the work of community health is multidisciplinary and involves a lot of sectors in order to make that happen, our organization has members from across the spectrum of community health. So we've got folks from community benefit and from healthcare working in population health, and also some people in community development and public health. And one of my goals would be to bring more community planners under our umbrella as we all work to improve the health of the populations that we serve. So healthcare, we hear about it a lot in the news these days, including an alert that just came through about what's happening with the ACA. But no matter what happens there, we're in a world where there's a new approach for hospitals. The photo that you're seeing on the slide is from probably my favorite ad that I've seen in a newspaper in the past 5 years from Sinai Health System in New York, saying that if our beds are filled, it means we've failed. And that's really flipping the healthcare model on its head. And what we call here at the association redefining the H, recognizing that hospitals are no longer solely acute care facilities that treat people when they become sick, but really they're focusing on quality, clinical integration, and population health. And recognizing that if they're really serious about keeping their communities healthy, that they're going to have to look outside their walls and come up with new models. And that means running in a way is a way to keep people out of hospital beds. And we are making progress towards that. And to do that, we have to be addressing the non-medical factors that keep people healthy and prevent them from being sick. So what makes people healthy? If you're in this work group, I'm sure that you're familiar with County Health Rankings and Roadmaps model. showing that really only 20% of health can be attributed to health care. The rest of it comes from factors outside of hospital and clinic walls. So research has shown that about 20% of that comes from genetics, and the other 60% are the social, environmental, and behavioral determinants of health. And so if we're thinking holistically about how to address health improvement, it becomes the hospital and health system's responsibility to start thinking about those determinants. So our group over here has a series of issue briefs and guides that are coming out, trying to show hospitals how they can impact all of the social determinants of health, including food, so food insecurity, food systems and food access, housing, making sure people have access to stable and safe housing. Education, we know, is a major determinant of health, so how both working on making sure that people are educated and how they can be health literate. Transportation, we know that being able to actually get yourself to a clinic for preventive care or specialty care is crucially important. Community violence, so what people are experiencing when they walk out their doors every day. Social support is a big one. Social isolation, especially as our population ages, has a huge impact on health. Health behaviors, how we live every day, what we decide to eat, what we buy at grocery stores, and last but not least, employment. So do people have jobs and professions? And all of these things, though not directly health related, determine whether or not people are healthy. So one platform that we've seen arise over the past few years that contributes to helping hospitals think outside of their walls is the Community Health Needs Assessment. And I think a lot of you are familiar with this, so I'll try to go over this briefly. A CHNA is a systematic process involving the community to identify and analyze community health needs and assets, prioritize them, and then implement a plan to address them. And so with the passage of the ACA, this became a mandatory process that all nonprofit hospitals have to do every 3 years. The first round of them was completed in 2013, and the second one was finished in 2016, and some of them are wrapping up now. So as part of this, and this is a pretty new process for hospitals, for people in public health, and I believe community planning, this community assessment process is pretty second nature. But in the healthcare field, this was new. So that first CHNA round, I kind of liken it to a fire drill. People had to figure out how to get the qualitative and quantitative data about their community, how to engage stakeholders in a new way, and really set up this new process to assess the health needs of their communities. The second round, it seems like it went much more smoothly, and people started to think more expansively and about the social determinants of health when making their priorities. So though this is a really important platform and a good springboard for starting to think about how hospitals can look outside of their walls, we know that the CHNA alone isn't going to revolutionize how hospitals relate to their communities and to the social determinants of health. It's a starting point and a really important one, we think, to get this process moving along and create some accountability in helping hospitals do this work. So in order to support the work of our hospitals as they're advancing their CHNA process, ACHI has updated our Community Health Assessment Toolkit, which you can see on the slide here, to provide a do-it-yourself approach for conducting a CHNA. And I think one of the key pieces about this one that is different from our original iteration is that we have community engagement right in the center. We know that hospitals and health systems can't do this work alone, and that they shouldn't be the ones solely responsible for improving the health of their communities. There are a lot of other players in the social sector that are in community-based organizations that are working on this as well. So having a coordinated, community-engaged approach is crucial, and I'll talk a little bit more about that. The other piece of this is that's key is that it's a cycle. Working on community health improvement is not something that you do once every 3 years and you stop and forget about it until the next cycle comes around. Once you plan your implementation strategies, you have to implement them and evaluate your progress and keep working towards improving until you start the process again. So we wanted to show that this is a continuum that is always going on and is really necessary in order to improve the health of communities. So a little bit about community and stakeholder engagement. We see this as really central to the CHNA process, no matter who you are, and that it benefits both hospitals and the community. So in terms of the hospital, it gives them a better understanding of the community that they're serving, including the social determinants of health that are impacting that community. It creates better community buy-in for the CHNA and implementation strategies, and it strengthens relationships with stakeholders. As hospitals are getting into this world of population and community health, they're having to form new relationships with unusual suspects, like potentially community planners. So this is a great opportunity to get those relationships started. The community also benefits greatly from being a part of this, and not just in a token sort of way where they're surveyed or part of a focus group, but really integrated into the CHNA process, because they can gain a new perspective of their community from a health lens that they maybe haven't had to think about before. There's a sense of shared commitment to improving the health of their shared community. They can apply their knowledge and experiences to the solution, and they're also more invested in the process. So then the next question is, who to engage? Do you just engage the public health department, or do you think more creatively? So my challenge to our hospitals when they ask that is always to think more creatively and widen the net of who is involved in their community health work. So for individuals, it can be community residents, people who are patients who are actually receiving care at the hospital, or family advocates, and try not to just hit the usual suspects, because we often hear that people who are involved in community work get over-surveyed, but try to reach out and get good representation from the community. But also stakeholder organizations and sectors like public health and housing departments, community development organizations, environmental organizations, schools and school districts, law enforcement agencies. We have seen all of these groups get involved in community health needs assessment and really add some depth to and breadth to the work that is being done. And that's where I think that community planners can really play a big role by getting involved in these CHNAs and then staying involved through the implementation side of it. I will roll through these step slides. So these are just kind of hitting on some of the steps in the pathways to give you an idea of what's involved in a CHNA if you haven't been involved in one. So there's a lot of collecting and synthesizing data. Hospitals can go out and get secondary quantitative data from public health departments to try to see where there are health disparities and what issues are having the greatest impact on the community, but also go out and do focus groups and interviews with stakeholders and community members to try to get a more nuanced view of how people are perceiving community health. And once you have all of that information, there's a process about prioritizing community health needs. And that's to distinguish the most pressing needs based on the data that's collected. So hospitals are required to use some set of criteria for prioritization. They can decide what makes most sense to them, and then go through this process and identify what they want to address. So the graph you see here is from a project that we did a couple years ago on the first round of community health needs assessments. It was from a review of 300 of them, gone through to code to see which were the most commonly prioritized community health needs. I don't think any of this would be particularly surprising to you. Obesity is, of course, at the top, followed by access to care and behavioral health and substance abuse. And we have done this with the rest of the sample of about 3,000 of them and get essentially the same answers. And I don't suspect any great differences in the 2016 one. People are still working on the same health issues, and we know that things like obesity and behavioral health and substance, like these aren't things that you can change overnight, even with the best strategies. That at the population level, it will take time and effort to move the needle on those. And then we start to get to what is really the crux of the CHNA process, and that is planning implementation strategies and actually implementing them. So we provide some tools to help our hospitals develop comprehensive and multifaceted strategies to address the community health needs prioritized in their assessment. And I should have mentioned on the slide before, hospitals don't have to develop or prioritize all of the health needs that turn up in their community, recognizing that that would be physically impossible. But they do still have to identify them and note that they are needs, just not ones that are going to be acted on in this round. So part of what we're trying to do in our social determinant series and the work that we're doing through the association is to show approaches to address some of those trickier, not traditional community health needs in order to start looking upstream and addressing those social determinants. So, I realize I'm getting to the end of my time. So yeah, we want to plan implementation strategies that are based in evidence, and do those, again, collaboratively and with community, because it doesn't make sense to reach out into the community to do the assessment and then retract to do the planning. These should be joint efforts in the community. And then, of course, implementing them. There's no reason to do this if we don't actually implement the strategies that we design. So that is really the work that gets done in the 3 years in between the assessments, and really where we'll start seeing impact in the health of communities. So to wrap up, we're in a new world of healthcare, and regardless of what happens with the ACA, we are moving in this direction towards thinking about value and population and community health, and how we can keep people healthy. So the health system of the future is going to be one that's listening to the stories of people in their communities and building trust and building a sense of community with the communities that they serve. And this really will help everyone with hospital utilization and helping people get the right care in the right place when they need it. And so that is the new world of healthcare we want to see. And we know that there's strength in community. We know that we're all in this together, that there are many sectors outside of health that are concerned with the health of the communities that we all serve. So as we move forward through this brave new world, we want to make sure that we're doing it together as a community, because we know we're all stronger when we're working in the same direction together than apart. And I'm happy to answer any questions.
All right, thank you, Julia. That was fabulous. Lots of great information, and we do have quite a few questions rolling in. So I'm going to go ahead and just dive right in. And certainly, Kayleen, feel free to jump in. I neglected to mention in my introduction of Kayleen that she was part of developing the first health and food system element for the Trenton Master Plan, and they really leveraged the Trenton Health Team and their community health needs assessment data, which was a fabulous example of bringing together planning and public health to support a needs assessment. So speaking of community health needs assessment, could you take a minute, Julia, and just explain the difference between a CHNA and then this audience member is wondering about the CHIP, Community Health Improvement Plan. So do they often work together, or is the public health department?
Yeah, so this is, it's purely an issue of like alphabet soup and acronyms. So when you talk to people about community health needs assessments, sometimes when they talk about the implementation phase of it, they call it an implementation strategy, and sometimes they call it a community health improvement plan. So they're all pieces of the same puzzle. I tend to, if you're looking at that community health assessment pathway, I tend to think of it all as like a CHNA process that aren't distinct from each other. But I guess I think they are one and the same in my mind.
Great, thank you. And on a related note, is there a central directory or location where community health needs assessments or CHIPs are stored, or do you recommend that planners or other folks on the line just go to their local hospital website, or how would one find this?
I promise I didn't plant this question to talk about a new project that we'll be launching soon, but as part of the work that we were doing coding all of our CHNAs, the other phase of that is that we are creating a website that is going to be housing links to all of the CHNAs, where you'll be able to search for them either by region or by priority or by type of hospital. So it'll be a map-based tool called CHNA Finder. We are in the final touches of getting that ready to launch. So at that point, you'll be able to go to our site and search around, try to find the needs you're looking for, the hospitals you're looking for, and then we'll be able to see what they've prioritized and link back to their website. But in the meantime, these community health needs assessments are all required to be publicly posted. So if there's a hospital that you're particularly interested in, you can go to their website and find it there.
Great, and actually that leads to another question. What do you recommend as really the first step? So if it sounds like this individual is a local planner and wants to get involved, is there typically a CHNA manager at the hospital, or how do you find the point of contact?
There typically is, and that person usually sits in the community benefit office. So part of the CHNA is it's an IRS requirement, and all nonprofit hospitals are required to conduct this community health needs assessment as part of their nonprofit status. So that usually runs out of community benefit, and I like to think of community benefit as like the public health brains of the hospital. They're the people who are getting out into their community and really know what's going on outside hospital walls. So if you can identify who's working in community benefit in a local hospital, that would be my first step.
And speaking of community benefit, we are getting a few questions about community benefit dollars. So are hospitals allowed to make investments in sidewalks and infrastructure near the hospital? Are there restrictions?
Yeah, they absolutely are. So that would fall under community building, which is in a slightly gray area in the world of community benefit. But yes, hospitals are definitely allowed to do that. And I think community benefit dollars are kind of a misnomer. I think there's this idea that there is this like pot of dollars that are labeled as like community benefit and need to be spent as such. In most hospitals, it doesn't really work that way. It's more of a seeing what the community health needs are and then making a case for investing in that. And if you can link a project back to a need that's found in the community health needs assessment, that really helps make the case that some of the like community building or infrastructure work near the hospital is in fact a community benefit.
Great, and I know we just have another couple of minutes. So I'm getting a few questions around the data collection side of things. And certainly it sounds like this particular audience member is interested in environmental health exposures and thinking about older housing, maybe in maybe the neighborhood surrounding the hospital. Are you seeing, what types of data sources do you kind of see on an ongoing basis? I know, of course, you mentioned the public health department and focus groups and interviews. Are there other typical data sources around the built environment or environmental health that you tend to see?
You know, I don't have a good answer for that question. I think that one's trickier. I've seen some instances, I actually heard one recently, about training community residents to go from house to house and check on the safety and environmental exposures in the various houses because there are a lot of issues with lead poisoning in that neighborhood. But I am not familiar with existing data sets that would link to that. I'm sure there are people out there who are, I just am not.
Great, and kind of in this data vein here, I know that as part of Kayleen's project, the planners leverage their GIS mapping skills to really bring some of this data to life. Is that what you're seeing with other CHNAs? Are folks really making the data accessible to residents or kind of sharing the data using GIS or other mapping type of software?
Yeah, I think there's definitely an effort to make the data more layperson friendly, realizing that if you're going to be telling the story of the health of your community, you need to be able to present it in a way that's accessible to people who aren't epidemiologists and biostatisticians. So yeah, mapping has been a huge help for that.
And then we've got a few questions around other potential partners. And so are you seeing a lot of universities engaged in this work or academic partners? And then also,
go ahead.
Also folks who are working with the disability community or others who might not always be represented in typical surveys.
So in terms of universities, absolutely. In a lot of cases, they're able to pull in the public health school as part of the process and for implementation because there's a lot of expertise there. In terms of the disability community, I think that where you're seeing that is in this second round of CHNAs, and hospitals have become much more intentional and thoughtful about how they're representing community voice and trying to expand who they're hearing from. And we know that is hearing the voice of that population is crucial.
Thank you. And actually, as we were discussing data sources and you were responding to the question about environmental health, other folks were chatting in different data resources that I'll plan to include in the follow-up email. But if you're on the line and you have other resources that you would like to share related to potentially data sets, data sources, or other partners for us to consider, definitely feel free to chat them in. I know we're just a couple minutes over, and maybe for our final question, where would you, and then this isn't setting you up, but where would you send folks who are looking for, we just have a few questions around templates and tools, and I know the toolkit itself is great, but are there other maybe focus group guides or other ways that we can kind of help streamline this process or help folks get the data that they need?
Sure. So that tool that I showed before, that's accessible on our website, healthycommunities.org. Other people who have really great resources on community health needs assessment is the Catholic Health Association. They've put together a lot of resources around community benefit that are incredibly helpful. There are so many resources out there, and a lot of them you can find on our website as part of the toolkit. The other thing that I love to plug is our upcoming Association for Community Health Improvement National Conference, which will be in Atlanta, March 14 through 16. And that's really your opportunity to hear not just about community health needs assessment, but this broader picture of what's going on in the community and population health world, and start becoming part of that conversation about how community planners can link up with all of these different sectors that are thinking about how to collaboratively make communities healthier.
Well, fabulous. I can't thank you enough, Julia and Kayleen, for being on the line. This was a wonderful action-packed 30 minutes. I will plan to include all of the links that Julia just mentioned now and that others have chatted in the follow-up email. You're also welcome to email health@planning.org or me directly, Elizabeth Hartig, Hartig, H-A-R-T-I-G, @planning.org. And thank you again for your time today, and we look forward to seeing you on our next HCC webinar.